Hi, Jay.
Hi, Sofian. How are you?
Good, very good. Thank you very much for being here. I am very happy that you are participating in our 37th meeting of the National Society of Orthopedic Surgery. Our meeting this year is held in conjunction with SOTCOT, ISACOS, and AO. I am very happy to moderate and participate to this symposium. Then I think Gregory is not connected yet, but you will start, and then we will let Gregory in the second one.
Okay, perfect. I will start my presentation
Okay.
on diagnosis.
Okay, you start your presentation, okay?
Okay, can you see my slides, Sophia?
Yes, yes, I see your slides, yes.
Perfect.
Perfect, let's start.
So much. Great. Thank you again. Thank you for the invitation to be part of this very valuable meeting in Tunisia. I wish I was there in person. I promise you to come and visit you in the future. I've been given the task of talking about diagnosis and update and what the options are. First of all, we know that there is no absolute test for diagnosis of periprosthetic joint infection. No test has 100% sensitivity and specificity. And in the absence of such absolute test, we need to rely on diagnostic criteria. And diagnostic criteria have been determined by various organizations, which I will share with you. But I think one of the most important work that was done is by the Academy developing an algorithm for diagnosis. And if you take nothing away from this talk today, I think this algorithm is something very important that we should definitely talk about. First, you need to suspect infection in any person presenting with painful prosthesis. Again, any painful prosthesis is infected unless proven otherwise. And once you see a patient with painful prosthesis, the first step is to order serology, ESR, CRP, and possibly D-dimer. If those tests are abnormal, or if they're normal, but your index of suspicion is really high, then you should aspirate the joint. And if you aspirate the joint, send it for cell count, neutrophil differential, culture, and any other biomarkers you're interested in. If the aspiration is negative, then you might want to re-aspirate the joint. If the re-aspiration is still negative and you can't get fluid, at that point you have two options, either to order a bone scan or to do a biopsy of the joint. I personally prefer biopsy over bone scan. So again, three very simple steps. Serology, aspiration. If the aspiration is dry, re-aspiration. If re-aspiration is still dry, then you do a biopsy of the joint. International consensus meeting modified that algorithm slightly. It's exactly the same things again, cell count, neutrophil differential. And then there might be a role for some of these biomarkers in some of these cases where you don't have enough data point to confirm or refute the diagnosis of infection. So these are the tests that we do currently. We've been doing D-dimer because it's a very good test to rule out infection. If D-dimer is negative, the likelihood of infection is very, very low. But if D-dimer is elevated, it doesn't mean the patient is infected, it just means you have to move to the next step of evaluation. And D-dimer appeared to have a better sensitivity and specificity than ESR and CRP combined. I like doing this particular test. This is urine analysis, a strip test. One part of this is leukocyte esterase. You drop one fluid onto leukocyte esterase. And if it's 2+ and turns positive, there's 100% likelihood that the patient is infected. This is colorimetric test, so you can't do it when the fluid is blood stained. So we usually just spin this down, get a clear fluid, and put it on the strip, one drop, wait for it. If it's 2+, again, 100% chance that the patient is infected. Alpha defensin has been around for a while. This is a test that looks for the enzyme in the synovial fluid, a measure of activity of neutrophils. But in recent year or so, we've seen that leukocyte alpha defensin has really no additional value compared to cell count. So because of that, we've abandoned doing alpha defensin at our institution. There was work by Jason Jennings from Denver that showed it was pretty much the same. Nick Bedard from Iowa has shown that alpha-defensin has really no role in reimplantation. And a recent work of Mayo Clinic showed that alpha-defensin has the same diagnostic odds ratio as PMN percentage. And that's actually not surprising because the alpha-defensin gets the same score in the ICM criteria as cell count. There have been other markers like calprotectin that Carlos Higuera and others have published on. And at this point, I think the role of molecular markers remains unclear. The diagnostic criteria that we used was the MSIS criteria that I was involved in development of and introduced in 2013. In recent 2018, we developed the international consensus diagnostic criteria. And this is good because it relies on one, pretest probability. It's actually been validated in multiple institutions. And using this criteria, preoperative diagnosis of PJI is possible. Whereas with the MSIS criteria, you needed to have some of these intraoperative tests to be able to confirm or rule out the diagnosis. The other thing that the ICM criteria has told us is that not all of these minor criteria have the same diagnostic odds ratio. ESR is not the same as elevated cell count. And if you look over here, again, elevated cell count has the same diagnostic weight as alpha-defensin, for example. So if a patient has a score greater than 6, they're definitely infected. If they have a score of 3 or less, they're definitely not infected. And the 4 and 5 are inconclusive. And we know that in real life, there are circumstances where we can't make the diagnosis and we need additional tests to be able to rule out or confirm the diagnosis. And the good thing about the ICM criteria is that it picks up some of these subtle infections caused by organisms like C. acne or even coag-negative staph. So about 20% of diagnoses of PJI that were missed by MSIS were picked up by the ICM criteria. And you don't have to remember those numbers. All you need to do is to download this app, ICM Philly, and over here, this PJI DX is the app that actually gives you the diagnostic certainty for periprosthetic joint infection. One other thing that I want to talk to you about is what do you do in circumstances where the culture is negative or you cannot, based on those tests, make a diagnosis? In other words, who needs additional testing? These are patients that are culture negative and patients in whom diagnosis can't be made with certainty. Culture is unfortunately very poor. It has about a 50 to 60% sensitivity. That is very, very low. We do have about 30% culture negative cases in my institution. And that shouldn't come to you as a surprise because organisms are not always planktonic. They reside inside the cells. They reside inside the canaliculi, and these organisms are not planktonic for us to be able to pick them up with culture. The slide here, at the top here, B, shows you that round body is Staph aureus inside osteoblast, a phenomenon known as internalization. At the bottom, these are dividing bodies with the yellow arrow. These are inside the canaliculi of the bone. They are invading the bone and they're destroying these purple-looking cells, multinucleated cells that are being killed as the Staph aureus continues to march inside the canaliculi. So it shouldn't be surprising that there is culture negativity. And then as we all know, most of the implant-related infections exist in the form of a biofilm, which then becomes impenetrable to host immune cells or antibiotics. And because of that, it's very, very difficult to isolate those cells. A new phenomenon called VBNC, these are viable but not culturable organisms, a phenomenon that was described in the 1980s, and Professor Lewis from University of Northeastern also developed this concept and matured it. This basically means that organisms can sometimes shut down into an inactive mode, G0 phase. They are not active metabolically, and hence they are not going to grow on a culture. But they are there as viable organisms, and if the circumstance changes and environmental factors change, then these organisms can sprint back into life and start to cause further infections down the line. This is a paper that was published in Nature, very interesting paper, and you can see how VPNCs are challenging situations in orthopedic infections and in even other types of implant-related infections such as endocarditis, shants in the nervous system, or even urinary catheters. Very, very interesting. And then finally, I want to tell you that culture is very primitive. Culture relies on all of these stars to line up for us to be able to isolate the organism. It's an 1886 technology, and in 1886, this is the state of transportation. This is how we gazed at the stars, and this is how we isolated the organisms. This is what we drive today. This is how we explored the galaxy, and this is still how we isolate organisms. So culture is primitive, and culture's got to change. It's like a fishing trip. You throw a net to try to catch the organisms. What is interesting is that only 2% of organisms are actually culturable. Yeah, 2% of organisms that exist in our bodies are culturable. And that's why during the international consensus, we discussed what additional diagnostic protocols are available for us to try to isolate organisms in circumstances where culture is negative. And discussions talked about repeat sampling, longer incubation, sonications of the implant, other technologies, including next generation sequencing. So we particularly rely on these pediatric culture bottles. We put our synovial fluid inside these and transport them to the lab. PCR and next generation sequencing have become very, very promising recently. NGS is used in urology. This is a study showed that when you relied on NGS and treated the patients based on NGS results, patients had much better outcomes than relying on culture. This is a study in New England Journal of Medicine in neurology, meningitis and encephalitis. When you relied on NGS, again, the results of treatments were much better than when you relied on culture. A large number of studies have also been published in orthopedics. We published a few things. We showed that you could isolate the organism in 90% of culture negative circumstances. And again, that PGIDX is very, very critical. And I think you rely on these to be able to isolate infection. So in closing, I want to tell you that the diagnosis of infection needs to rely on a combination of tests. We need to rely on algorithm, which will tell us where we stand. In culture negative cases, molecular techniques have very promising role and should hopefully change the way we treat these patients in the future. Thank you for your attention, and I will stop here.
Thank you very much. Thank you very much, Jay, for this very interesting and mainly for the new molecular techniques. My question is for the regular routine situations. What's the time that you recommend between you do your debridement and send the samples to the lab and the time it will arrive to the lab? Yeah. And what are the precautions that you should take in account? Because in the treatment I will speak about the number of samples and so on. But what is very important for the tests that you rely on the vials that you have pair up, what are in practical situation how it happens?
Yeah, great question. So when you take the samples of culture, first of all, take it from the area where you think there's a high likelihood of infection, like the interface between the implant and the bone, intramedullary canal. Those slimy looking tissues are really good. Take it with a clean instrument, not contaminated instrument. Transfer that directly into the culture bottles. Don't put it on somebody's hand. Don't put it on the back table. Don't put it on the gauze. Directly transfer into the bottle. Take 3 minimum samples, maybe 5. immediately transport them to the lab and call the lab and let them know that the sample is arriving. To your point and the question, Sofian, 1 hour is the recommended time that IDSA talks about. So you should get all these samples to the lab within that hour, preferably shorter. If you have synovial fluid, make sure it goes into that pediatric orthopedic blood culture bottle. Let the lab know that as soon as the sample arrives, they need to incubate them. You don't want these samples to sit on the side and dry out. They need to be incubated in aerobic and anaerobic. In circumstances where you have a patient that has a high index of infection suspicion for fungus, you should also ask for fungus. If you think the patient may have atypical organisms like Mycobacterium, you must ask for that because the lab doesn't routinely do it. And finally, one question that comes up is how long should you hold the culture?
Yes.
5 days. But if you have a culture negative case, you may want to hold it all the way out to 21 days. Because some organisms like P. acne or C. acne grow very slowly. Sometimes atypical bacteria like Mycobacterium grow over 21 days. So you should hold it longer in infections that are culture negative.
Thank you very much. Are there any questions from the floor? Okay, then if Gregory is connected, we will have the talk of Gregory. No, Gregory is not connected, Jay. Then I will give my talk about the treatment.
Perfect.
Thank you very much for being here this afternoon for the treatment of the PGI. And I changed my talk regarding the previous talk that you had this morning with Johnny Abdenour when he talked mainly for the clinical issues. And I will give you mainly the recommendation in what do you need and what are the learning outcome of this talk. Is how to discuss what are the different treatment for different aspects of stages of PGI. What are the treatment options for each situation? What are the recommended attitude, and mainly what is the evidence and the consensus recommendation that we have for PGI? What are the errors to be avoided when you are treating PGI? And the last topic is the new aspect and research pipeline in treating PGIs. Non-operative treatment is medical treatment with a chronic suppressive antibiotic. What are the indications of this situation is patients which are unfit for surgery, that couldn't have surgery, patients who refuse surgery, systematic spread and maintain of joint motion with systematic relief. And in such situation, the outcomes are between 10 to 25 success rate of eradication, mainly in elderly people, and 8 to 20% complication rate, mainly for DVT and PT. The indication of operative treatment with polyethylene exchange with component retention, the second situation, with IV antibiotics for 4 to 6 weeks with debridement and irrigation, which is called by diarrhea. The indication are acute infection less than 3 weeks after surgery, or acute hematogenous infection with weak literature ideally before 48 hours to 72 hours. In such situation, the outcome are more poor, and those tissue debridement and irrigation with large volume of irrigation, 50 to 55% of success rate. The implant must be removed if reinfection is documented and dependent of the bacteria aspiration. The operative technique is as follows. And the question is, should intraoperative culture be taken when performing irrigation debridement for prostated draining and wound after total joint arthroplasty? The consensus is yes. If intraoperative culture, minimum of 3, as suggested by Jay just before, should be taken when performing irrigation and debridement reoperation for persistent draining wound. Should perioperative antibiotic be withdrawn prior to skin incision for irrigation and debridement? The answer is no. Perioperative antibiotic given within 1 hour prior to irrigation and debridement operation should be not withheld prior to skin incision. It's after skin incision. Modular part should be removed because there is a fibrin layer just behind the plastic and metal part which acts as a medius for infection. Polyethylene exchange. Be sure that the component is available before going to surgery. Be sure that you can exchange exactly the same item that you are removing, and use monofilament suture for wound closure. Irrigation and debridement. The question is, when performing irrigation and debridement for hematoma after total knee or total hip arthroplasty, should the deep fascia be opened? The answer is yes. What are the contraindications of irrigation and debridement? The consensus said that the inability to close the wound or to presence of sinus tract are absolute contraindication for irrigation, debridement, and retention of the prosthesis. You have to exchange the prosthesis. Another absolute contraindication is the presence of loose prosthesis. Once it is loose, you have to change it. The one-stage replacement arthroplasty, we will go slowly, very less complicated to more complicated situation. Instead of exchanging only the liner, you have one-stage replacement arthroplasty. This situation is a little bit tricky. Why? Because the indications are limited and mainly in our environment. Use it more commonly in Europe than in other continents. No sinus tract, healthy patient, soft tissue, no prolonged antibiotic, and no necessity of bone graft. This is all these conditions should be here. And low virulence of organism, no virulence of organism. In such situation, the technique is use antibiotic impregnated cement when you exchange the prosthesis. The advantages are lower cost and convenience with single procedure. Early mobility. Disadvantages, high risk of continued infection from residual microorganisms, and the outcome rate is between 75 to 100%. What's the consensus about the one-stage exchange? What are the indication and contraindication of one-stage exchange? The consensus says that one-stage exchange arthroplasty is a reasonable option for the treatment of periprosthetic joint infection in circumstances where effective antibiotics are available. It means that you should know the microorganism before and to be sure about the type of antibiotic that you are using. Not in patient with the systematic manifestation of infection sepsis, then you cannot do one stage in such situation. In home resection, arthroplasty and reduction is bioburden may be necessary. Relative contraindication, lack of identification of organism preoperatively. Then because you are not sure about the type of antibiotic that you are using in post-op and the presence of sinus tract or severe soft tissue involvement are contraindication of one stage replacement. For antibiotic to use, how long should antibiotic treatment be given following a single stage exchange of arthroplasty for PGI? There is no conclusive evidence regarding the ideal duration of antibiotic therapy for single stage exchange, and we recommend the parenteral antibiotic given for 2 to 6 weeks following single stage exchange arthroplasty with consideration for longer term antibiotic therapy. Two-stage replacement arthroplasty. We are going, as I said, gradually more complicated. Indications are the two-stage remain the gold standard in infected BGI, mainly for more than 4 weeks after arthroplasty. Must be medically fit for multiple surgery. Patients should resist to this type of surgery, which is a lot of complication. Require adequate bone stock, not very loose bone stock. Require confirmation of microbial eradication, that you have to try to identify the microorganism. benign clinical exam, normal labs, negative aspiration cultures, and obtain repeat culture at least 2 weeks after planned antibiotic course has been completed, as it was mentioned by the previous talk. Then the procedures removal with antibiotic spacer, IV antibiotic for 4 to 6 weeks, and delayed reconstruction. What are the indications for the two-stage exchange arthroplasty? Two-stage exchange arthroplasty is a reasonable option for this treatment. In patients with systematic manifestation of infection, scenario where infection appears obvious but no microorganism has been identified, then you eliminate the one stage here. Preoperative culture identified difficult to treat antibiotic resistant. If microorganism is identified but it is difficult to treat, you should go for 2 stages arthroplasty. The presence of sinus tract and inadequate non-viable soft tissue coverage. The outcomes: bilateral totally arthroplasty reduction arthroplasty followed by 6 weeks of antibiotic, and bilateral reimplantation has excellent results as 2-year follow-up. Delayed reimplantation more than 6 weeks has 70 to 90% success rate, and cementless reimplantation of the hip has better outcomes than cemented if the conditions are required and you have high quality of bone stock. The technique of 2-stage: you have to explant the prosthesis to do a large debridement, must debride bone implant, the interface to eliminate the biofilm and to excise the soft tissue, antibiotic spacer with IV antibiotic. Advantages of spacer: reduce the joint dead space, provides stability of the hip or the knee when it is stable. Potential local systematic allergic reaction, increases chance of developing antibiotic resistant for microorganism, and only heat stable antibiotic can be added to cement. I will detail this point. Then advantages of static spacer: allow delivery of higher doses of antibiotic, better wound healing since it is stable. Advantages of articular spacer: decreased reimplantation exposure time, better maintenance of jaw space, decreased quadriceps shortening in total knee arthroplasty, and better outpatient satisfaction. Now, is there a functional difference in the use of non-articulated and articulated spacer for the treatment of PGI? 2 stages. All well-performing articulated spacers provide better function for the patient in between the 2 stages, total hip or total knee arthroplasty. They are statistically preferred for patients who likely have a spacer in place for longer than 3 months, when the spacer will be for a longer time. Then each bag 4 grams of antibiotic and 3 grams of vancomycin. Gentamicin may be substituted by tobramycin. Elution antibiotic depends on the cement porosity, the type of cement, the surface area, and antibiotic concentration. Must use heat stable antibiotic: vancomycin, tobramycin, and gentamicin that most use. What about using local antibiotic, the powder or vancomycin? Properties: active against the microorganism, can be incorporated into delivery like the PPMA, aminoglycoside, effective against gram-negative and bacilli, synergistic against positive gram-cocci, low risk of systemic toxicity. Vancomycin effective against the gram-positive cocci with excellent elution properties. Local antibiotic for cement is low dose, 2 grams of antibiotic, 40 grams of cement. Commercial antibiotic cement is low dose. These are the different type of cement that you can have on the market with the different doses that you can have. The elution property depends on the type of cement that you are using. The rapid release, the initial, is mainly in the first 24 hours, and even the technique can change. It depends on the type, but the low level lasts at least 5 weeks after putting the spacer in the hip or the knee. Il y a un problème avec la télécommande. What are the indication of knee arthrodesis in some cases? Not the indication of knee arthrodesis if you can afford after 2-stage arthrodesis or disarticulating. The literature is deficient in providing guidance on this issue. Knee arthrodesis may be appropriate option for patients who had failed multiple attempts to reconstruction and stand an unacceptably high risk of recurrence of infection. We can even problem là. PGI can be a source even of amputation if you cannot control the infection, the indication or total knee infection recalcitrant to other option with unfit patients, severe pain, soft tissue problem compromise, and severe bone loss or vascular damage could be an indication for amputation. Aside of type of treatment, it's very important just to remind what are the errors that we have to avoid when treating PGI. The first point is delaying of diagnosis. Your behavior shouldn't be to ignore the existence of PGI and put the pain of the patient in control that it is post-op normal post-op pain. Infection should be ruled out in any patient with persistent wound leakage or warm, swollen, or painful joint. The pain is the most common error that we have. Unfortunately, it is common to minimize the problem, taking a wait-and-see approach, losing valuable time. The effectiveness of debridement, antibiotic, and implant retention, like we described it in the first step, decreases the surgical delay and less risk. Second error is conservative treatment with antibiotic in early infection. If it is infected, you have to treat the patient as infected PGI, not as any infected patient for pulmonary or any other problem. Antibiotic treatment is commonly initiated in cases of fever, chills, persistent inflammation, wound drainage, following joint cytoplasty for surgery. It is difficult to differentiate superficial wound infection from early postoperative prosthetic injection and wound issue as a risk factor with PGI. Then you need prompt surgery for these patients, and suppressive antibiotic therapy has limited clinical efficacy since the patient is already infected. Antibiotic prior to microbial diagnostic. As Jay before insisted on the point, if the first aspiration is negative, do a second one after 15 days and try to recognize if there is infection in the periprosthetic joint aspect. Arthroscopic lavage. Arthroscope is contraindicated in PGI. Arthroscopic lavage of an infected prosthetic joint does not allow access to the part of joint, particularly posterior part of the knee joint and the polyethylene layer and backside in knee as well as another joint. In addition, it does not allow exchange of mobile part because we said the first step is to exchange the mobile part in arthroplasty. Then in prosthetic hip joint debridement is efficient without dislocation of the femoral head, which is difficult to perform with any arthrotomy. Another error is insufficient debridement or incomplete exchange of implant. A common reason for treatment failure is inadequate debridement. All the mobile parts should be changed, and infection with mature biofilm or foreign material, including cerclage and bone cement, should be removed. High pressure lavage during surgery. Pulse lavage is commonly used in PDGI. In the clinical setting, the success rate in treating orthopedic implant-related infection is similar when using high pressure and low pressure pulsing lavage. There is no need to pulse lavage. Using antibiotic-loaded cement spacer. The use of antibiotic-loaded cement spacer in two-stage revision has two goals. It provides local delivery of high doses of antibiotic above the minimal ambulatory concentration normally attainable locally with systemic treatment without adverse effect. Common pitfalls are using antibiotic inadequate for mixing with bone cement or that are not effective or the type of microorganism. If the microorganism is For example, vancomycin is not good for gram-negative. It is for gram-positive. Then you have to choose the type of antibiotic with the cement. Antibiotic holidays, joint aspiration before reimplantation, two-stage exchange, no holidays of antibiotic. Error in antibiotic treatment. The selection of antibiotic treatment should be based on the type of microorganism and drug susceptibility and the type of surgery which is performed, one stage or two stage. Not all antibiotics are equal. In two-stage ECMO, we do not recommend using antibiotic in prosthesis-free interval, but rather than initiate them once the prosthesis has been reimplanted. In one-stage exchange and infection treated with debridement and irrigation, biofilm active therapy should be initiated post-op as soon as wounds are dry and the drain are removed, then initial. Another error is prescribing oral antibiotic with bad bone penetration. This is another error. And furthermore, single drugs regimens such as rifampicin monotherapy should be avoided in order to minimize the risk of selecting drug-resistant microorganisms, no monotherapy. Inadequate management of soft tissue. This is a big issue because occasionally there are difficulty to adequate closure of soft tissue with the envelope surrounding the joint. A plastic surgeon should be consulted because any exposed prosthesis will quickly be colonized by microorganisms and covered with biofilm. Wound revision with revision of the prosthesis is necessary, is always indicated as the only way to guarantee a favorable outcome from both infection and from functional point of view. Negative pressure wound therapy should not be used in PGI. Another error, never use X-Fix on an infected prosthesis around the prosthesis. Last point is the lack of specialized multidisciplinary. Treating PGIs is a team work, not a surgeon work only. Diagnosis and treatment of PGI involves multiple steps, including, but not limited to, evaluation of the patient, particularly the affected joint, interpretation of synovial fluid, analysis of bacteria, culture result, development, execution of surgical plan, and the choice of antibiotic treatment should be done with infectious team. This involves microbiologist, infectious disease specialist, orthopedic, and plastic surgeon for soft tissue. What are the new aspects we are talking about today in treating PGI? Two main aspects: FASH therapy in PGI, a new antibiotic emerging, dalvabicin. FASH therapy is discovered more than 100 years ago, which is a group of viruses that infect only bacteria, including pathogenic microorganisms. And it was used since, as I said, 1919 in France. But we started to see the effectiveness of FASH therapy in affected PGI, and our Germans are doing more job on it. But actually, we don't have a lot of data, but we have that the FASH improves the activity of antibiotics. This is the element that we have today. A new antibiotic, the dalvabicin, a new antibiotic for osteoarticular infection. It is a ligococcolipeptide antibiotic, activity against mainly gram-positive, terminal life 2 weeks, plasma concentration 7 to 14 days, and we are actually at phase 3 of trial with some side effects like diarrhea, nausea, and kidney failure. Then it is a study which has been with the effort group of post-interventional perspective with 64 cases. The reason of switching to dalvabicin regimen simplification because it's very short treatment. Adverse effect 25%, treatment failure 21%. And we need more prospective study to see the effect of dalvabicin, which is very, very expensive at the moment, and the good promising because we have the current data is promising with often observational and non-comparator. Now, it has a good safety profile and provides a simplified treatment regimen and study in pipeline Prodalba. What are the take-home message? Management of prosthetic jaws infection is a big challenge. Diagnostic, the surgical strategy should be well established in a multidisciplinary team. As I said, it's a team work. There are many possible sources of errors in the diagnosis and the treatment of this patient. Be aware about that. Understanding of the biology, different tests of the infection, and the advantages, limitation of existing diagnostic technique and surgical option is essential, as it was specified by the previous talk of Jay Parvizi. Awareness of the potential pitfalls, the error you should avoid, all these errors that we already talked about, and systematic approach can improve the likelihood of success. Thank you very much.
Thank you very much, Dr. Khalil, for this excellent presentation. I have two questions. So, concerning the early infection, that is an early infection after arthroplasty, beginning some days after surgery and before the 4th week. So, how many time we are allowed to do irrigation and debridement if we don't have an organism or pathological organism in the culture? Does it mean that we are allowed to do it twice, third time before explantation? And the second question, sometimes in total hip revision surgery, some surgeons recommend to do culture. And in 5%, 7%, we have positive results. After this revision arthroplasty, what we shall do? We shall give antibiotics, or what we shall do exactly? Because it's sometimes it's the case that we have found.
The answer of the first question was in the previous talk with the Jay Parvizi, because he presented the algorithm and how to do the aspiration. If the aspiration is negative, you do it a second time. If it is negative, you have a specific test. It's positive, you consider it as infection, and you go for debridement, irrigation, and so on. Second question is to have at least 3 to 5 vials per up. You have to advise the lab before doing the surgery. The time the vials should be done and put in the direct culture system, not in a bottle or whatever, and to take them to the lab and then for culture. You have put your vials in the culture system directly in the lab, and to coordinate with the lab. The maximum of time authorized is 1 hour. More than 1 hour, you have a lot of chance to lose your test.
I'm asking about revision surgery.
Yes.
Does it mean that we made the spacer, and after, for example, 2 months, after 6
4
weeks,
to 6 weeks.
we are going to do revision? At that time, we do
Two situations.
Two situations.
Two situations. If you come back and you have good fibrosis around the spacer, white fibrosis is good. It's remain inflammatory. You remove the spacer, take new samples, new spacer, and then go back.
Okay.
If there is inflammatory conditions when you remove the first spacer, don't put your prosthesis. Take new samples, because normally if you are controlling the infection, the reaction to the spacer should be good. If the reaction of the spacer is not good and you have inflammatory reaction around the spacer, take new samples and go back and zero.
Step by step, another time.
Yes.
Thank you. Is there any question? The audience?
Thank you very much.
Can I review Gregory?
Thank you, Jay, for assisting. If he's still connected.
Not yet.
Jay, do you have any comment?
I'm so sorry. I was talking while I was on mute. No, thank you very much for incredibly useful call. I'm sorry that Greg couldn't be on the call, although he had
No
told
problem.
us that he wasn't going to be able to make it in person.
Then we will make it next time in person, face to face.
But same.
Okay.
I would love to see you. Thank
Love
you
to
and
see you.
have a
Thank you
great
very
day,
much.
everybody.
Thank
have a
you.
great day.
Bye-bye.
Bye-bye.
Now you go for the symposium of periparasitic fractures.
everybody, and welcome to this last symposium of the day dealing with periprostatic hip fracture. Total hip arthroplasty is a very successful surgical procedure, and it rises in line with the aging of population, and even is done in people, young people with high demanding activity. But as there's a high number of total hip arthroplasty, there's also a severe complication, which is fracture of the periprostatic fractures. It's the third cause of revision surgery, with an average incidence of 2%, and very technically demanding complications that occurs more frequently on the femoral side. It appears on the rise because the huge amount of total hip arthroplasty implanting. So this is the agenda for the symposium. There's different sections. We'll begin with the risk factors, then the classification, then prevention and management of intraoperative periprostatic fractures, the fixation techniques in 2022, the stem revision, and the outcomes following surgical treatment. Most important thing is to study the risk factors, as prevention is better than cure. This is why I have done a search on PubMed with the keywords periprostatic hip fracture risk factors. I found 483 results. I applied some filters, so publication date within 5 years, and the article type, clinical trial, meta-analysis, randomized controlled trial, and schematic review. So then the number of articles was 15. This is the first meta-analysis conducted till November 2018. There were 70 studies and number of patients of 90,632. The risk factors were female, gender, pre-operative diagnosis of rheumatoid arthritis, and cementless stem. Second schematic review and meta-analysis was about 18 studies with 12,868 periprostatic fracture. Two-thirds was post-primary THA and one-third post-revision. And the risk factors were 60% in females, 39% Vancouver B2 type fracture, and the revision was 3 times of risk compared to primary implantation. This meta-analysis dealing with 16 studies and about 4,253 patients. The risk factors were female, revision with 3 times risk, and rheumatoid arthritis. So there's 3 items which are very important in dealing with risk factors, which are poor bone quality, mechanical stress risers, and neurological disorders. So the factors which are weaken the periprostatic surrounding bone are age, more than 70 years, female gender, medical records, osteoporosis, thin cortices, champagne fluid type proximal femur, and rheumatoid arthritis. Also, there is dysplasia, hardware that require removal in the perioperative period, radiation therapy, high body mass index, and cervical myelopathy. There are also mechanical stress risers, were defined to occur in the presence of stiff orthopedic implants and lung bones, which are malpositioned stem, loose implants, and local osteolysis. These neurological disorders were predisposed patients to mechanical falls and no need for a high energy force to produce a periprostatic fracture. What about surgery and implants related factors? The surgical approach. We know that anterior approach, there's a rise of number of surgeons who are performing anterior approach. There's a high risk, till 8 times compared to the Moore approach when with the anterior one. The handage also with the calcar fracture, more than anything when we use the collar stem, the cortical defects, the semen-less femoral components, and the implant design. I'm talking about the double-wedged stem compared to the tapered one. And also the revision surgery. Here, as we can see, the stress shielding, which causing femoral fracture. And for the short varus stem, also has a high risk of periprostatic fracture. As we can see, there's a difference between the collar stem and the varus stem with the short length. There's more risk with the short stem compared to the long stem. Also, in case of subsidence of the and loosening of the implant, there's a high risk of fracture. It is, as we can see, like a line wear up on the stabulum and loosening and a fracture of the stem. The morbidity associated with periprostatic fractures is significant, with complication rates reported as high as 45% following surgical management. Furthermore, mortality rates in the acute phase are similar to those found with native hip fractures, while mortality rates dip below those of native hip fracture at 6 months and 1 year time, nearly 10%. So these are broadly the 4 items related to the patients, all the A's, steroid use, rheumatoid arthritis, and stress shielding. The prosthesis-related factors whose loosening of the implants, local osteolysis, and stiffness, and the increased in fall risk. Thank you. So I'm calling Dr. Mihoubi to speak on classifications of periprostatic hip fractures.
Thank you, Dr. Barsawi. So we'll move to classifications of periprostatic fractures. So I have no interests, no conflicts of interest. And as we know all, a classification system is a communication tool for clinicians and researchers. A good classification should predict diagnosis and dictate management. So the question is, are existing classifications fit for periprostatic hip fractures? Now, let's move to periprostatic acetabular fractures. These acetabular fractures are uncommon. They occur in 0.4 to 0.02% intraoperatively in case of cemented or uncemented prosthesis. Let's say 1% of revision total hip arthroplasty postoperatively, so they are very rare. And they occur because of poor bone quality and especially for poor cup positioning. The prognosis is dependent on the integrity of the posterior column. We should distinguish between intraoperative periprosthetic acetabular fractures, which their main cause is impaction during the operation. The acetabular component seems to not achieve the expected press-fit position. It protrudes more medially than needed. So if we make a plain X-ray, we will see that there is an acetabular fracture. What are the risk factors? Maybe under-reaming superior to 2 millimeters, maybe hemispherical cup, maybe, or let's say poor bone quality and poor cup positioning are the main risk factors, and the treatment depends on stability and displacement. Whereas postoperative periprosthetic fractures are caused generally by a mild trauma. It's diagnosed on plain X-rays, and the risk factors are poor bone quality and revision surgery. The treatment also depends on stability and fracture pattern. There are many classifications of acetabular periprosthetic fractures, such as the Callaghan classification. It's the third classification. It's an anatomical classification. Anterior wall fracture, transverse, inferior. There is Davidson classifications according to fracture stability, undisplaced fracture with the stability of a reconstruction or not. But the more interesting classification is the Pascarella classification, which distinguishes intraoperative fractures with stable prosthesis that need conservative treatment to increase primary stability. This is an example. Or an unstable prosthesis, and then we should make ORIF. Concerning postoperative fractures, the prosthesis may be stable, and then we may conservative treatment or ORIF, or unstable prosthesis. And here we should distinguish between unstable prosthesis that was mobilized before trauma or while at the moment of the trauma. This is important because, as you see, we will seek loosening around the acetabular cap, and this will make difference in surgical management. And when we talk about bone loss and loosening around acetabular cap, we should think about the Paprosky classification. But pay attention, there is also another Paprosky classification of periprosthetic acetabular fractures, or Dal-Laval classification, which is a descriptive classifications, intraoperative, traumatic, spontaneous, or with pelvic discontinuity. And the Paprosky classification, which is well known in revision total hip arthroplasty, which describes acetabular bone defect in order to dictate the possibility of cementless fixation or to bridge the bone loss according to the amount of acetabular bone loss. So the Paprosky classification in late stages may be described using CT scan, but for stages 1, 2, and 2B and C, intraoperative assessment remains superior to CT scan. There is also the American Association of Orthopedic Surgery classification, which is similar, and the United Classification System, which is the standard coding scheme of OTE classification system, which distinguish the 5 types of apophysis bone fracture, periacetabular bone fracture, extraarticular fracture, and interprosthetic fractures. But as you see, it's not well, it's too complex for acetabular periprosthetic fractures. So, to summarize, treatment depends on the stability of the implant in case of periprosthetic acetabular fractures. A sufficient bone stock is mandatory, and fracture stability may be discussed after taking acetabular implant stability into account. And when we seek stability of fracture, we seek posterior column stability. So let's say a management algorithm, there are several management algorithms. For example, the 4R management, we consider removal of implant, we consider restoration of bone defect, reconstruction of colons, reimplantation of prosthesis. When we respond to all these questions, we will see different situations, and this is an algorithm. But Ginsland et al. Talk about acute acetabular fractures and late acetabular fractures, and maybe in the future we will be talking about two clinical and radiological distinguishing features between acute and late acetabular, postoperative acetabular fractures. It's not okay. Now we'll move to, acetabular fractures are rare, are quite rare. We'll move to periprosthetic femur fractures, which are much more frequent and are expected to increase. Over 75% of all postoperative fractures are related to loose implants, which may cause several issues, diagnostic and management issues. To classify periprosthetic femur fractures, there are different classifications, historical classifications, but the Vancouver classification is still used. Pay attention, there is Vancouver classification for intraoperative periprosthetic femur fractures, which is less used, and the reliability and validity have not been yet tested, and the Vancouver classification for postoperative periprosthetic femur fractures, which all we know, and distinguish the A, B1, B2, B3, and C subtypes. Classification depends on location, stability of fracture, and stability of implant. This is useful for and reliable for surgical planning. It's so quite easy. It's widely used. It's widely used, but the unified classification system has been proposed. Why? Because it combines Vancouver classification with AOOTE classification. And this combination takes much more situations such as interprosthetic fractures, which are not included in the Vancouver classifications. So it's more adapted for periprosthetic femur fractures. And then there is a race between the Vancouver and the UCS, and the race has begun. This is a systematic review to compare the reliability of the Vancouver classification and the UCS classification. And as you see here, the Vancouver Sunrun So the Vancouver has won, and today the Vancouver classification remains the leading classification. So you see that the much more studies use the Vancouver classification than the unified classification system. But aren't there weaknesses of Vancouver classification? We said that in the beginning that a good classification should predict diagnosis, and in that case, it should predict preoperative planning. As we saw with Dr. Barsawi about risk factors, the Vancouver classification did not inform about fracture pattern, about implant design, about cemented and uncemented implants, about patient-related risk factors, and it doesn't dictate management. So we can't say that type C, for example, we should perform fixation, we should perform stem revision. We should perform a cemented stem revision for type X or Y. So these are weaknesses of Vancouver classification. For example, treatments of Vancouver B1 and C fractures may be the same. Distal C fractures are often treated with retrograde nail, whereas proximal C fractures require plate fixation, so it doesn't dictate management. The B3 fractures with loose implant, sometimes it should be considered as pathological fractures, so how it could dictate? Maybe it's infected, maybe there is a tumor. So, apart from these inherent weaknesses, there is also some ambiguities. In this plain radiograph, is it B1 or B2? How do we assess and confirm the stem stability? Maybe the fracture of the cement mantle is useful data, is useful information, but we need, in practice, to test the stability of the implant. And this will need more exposure, more unplanned joint exposures, and maybe femoral osteotomy and potential for postoperative complications that were not planned. That's why some authors try to subdivide the B2 type in B21 subtype with one only fractured zone, and the B22 type with two or more fractured zones. In B21 type, the stem is stable, and in B22 type, the stem is always unstable. In this plain radiograph, is it B2 or B3? Knowing that perioperatively the stem, is there any bone defect or not? So these are some situations where Vancouver classification has some weaknesses, and that's why many authors seek to propose new classifications. But these propositions are much complex and maybe not easy to use in practice. And these classifications don't dictate treatment. So, for example, in this subtype of FS subtype, it propose logical individual treatment. What does it mean, logical individual treatment, if we use a classification? Then the fracture pattern. Is there extruded cement? Varus, we know that it's not the same situation when the stem is varus or when there is varus or valgus stem position. Should we use stem revision? Yes or no? But we don't know whether there are shape differences. There are differences between periprosthetic hip fractures according to the shape of the implant, the stem design. There is so many shape differences, and that's why we should take into consideration these differences, not only concerning the shape, but also concerning the size. Short stems, short metaphyseal stems. Too much short stems, these are differences between stem design. But what we know is that the Vancouver classification is less reliable in uncemented stems. So the confidence is about 42%, which is very low for a classification. And that's why radiographic assessment alone is inadequate to determine stability of cementless stems. Also, when we talk about cemented stems, there are different evolution and different clinical features. The stem, the cemented stem, is like an axe splitter. So he acts as a splitter. And should we perform cement in cement revision, cement resection with revision? All these are questions about management that we will talk about later in this symposium. But there is some classifications about the use of cement or uncemented stem, femoral stem, like the BABA classification, which distinguishes a fracture around an uncemented stem and a fracture around the cemented stem. This fracture may involve the porous coated region or outside the porous coated region. That means involve the implant or outside the implant in case of cemented stem. This is an easy classification and takes into consideration the type of stem, of femoral stem. So, the future, we should take into consideration the type of implant, the damaged implant, stable, unstable implant, the loosening, the quality of bone, the existence of infection, and we should also think about patient status, available implants, and surgeon's experience as well, but confirmation of stem stability still be performed during surgery, which must be avoided in the future. So to take-home message, treatment of periprosthetic hip fractures depend on implant stability, fracture stability, and bone stock. Cemented and uncemented femoral stems have different mechanical, clinical, and surgical features, and the design of implant should be considered in future classifications of periprosthetic hip fractures. I'll take and I'll call Dr. Zitouna Khaled for prevention and management of intraoperative fractures.
Thank you, Mamoun. We will talk about prevention and management of intraoperative periprosthetic fracture. It's one of the major complications of THA, may affect implant stability and survivorship. Many different treatment options exist, but no single treatment has been shown to be the gold standard. Femoral fracture have received greater attention in the literature than have acetabular fracture because difficulty in identifying intraoperative acetabular fracture at the time of the operation. We start with the case that show the gravity of this lesion for a man at 37 years with osteoarthritis bilateral, left THA, no problem, but in the right, no problem, but in the left, an operative fracture with infection and shortening of limb. Wrist fractures. Several authors have reported diverse wrist fractures of intraoperative, and if you are a female with osteoporosis, metabolic or inflammatory disease with a use of a press fit stem, you are at a high risk of this lesion. Intraoperative fractures concern two sides of the joint. So we divide this presentation into steps: femoral and acetabular fractures. Increased risk in association with the cementless stems, as we said in a past presentation, especially in the revision, due to need for press fitting of cementless stems in conjunction with the bone loss typically associated with revision total hip arthroplasty. Sudden change in resistance is highly suggestive of the diagnosis. Intraoperative review should be made to rule out fracture when a concern is raised. Non-displacer fracture may not be visualized on radiographs, so combine intraoperative clinical assessment with imaging findings to diagnose all the fractures. The principles of treatment are ensuring stability of THA, avoidance of fracture propagation, maintenance of component position and alignment. Vancouver classification, as said, is the most frequent and the most used classification. And in contrast to the Vancouver classification for post-op, its reliability and validity have not been used. There are three types: ABC, A for metaphysis, B for diaphysis around the stem, and C, diaphysis far away the stem. Three subtypes for each type. One is perforation, two is non-displaced, and three displaced or unstable component. So for the first type, the type A1, fracture in metaphysis with perforation are fractures being stable, and the bone graft alone is sufficient. For type I2, you can do a circlage wire, like in the pictures. For type A3, circlage with or trochanteric plate. For type B1, we do make bypassing the affected area by 2 cortical diameters with long stems, like in this example. For a non-displaced, we can use a plate, like in this example, and we don't we cannot accept this type of osteosynthesis of solution because it's prohibited, because it's the risk for revision. It's not stable management. For type B3, it occurs during hip dislocation, cement removal, and final stem insertion. And the solution is bypassing the fracture site with a longer stem like B2. For type C, 1 or 2, circlage wire and augmentations with an allograft cortical strut must be made. For type C3, it's mandatory to open reduction and internal fixation. The treatment, the reported results of treatment are difficult to compare because there are many strategies for fixation. No comparative studies to our knowledge and a lack of consistency in the classification. Now we move to acetabular fracture. They are less commonly recognized than femoral fractures because the type of the fracture. They are most common with the uncemented cups. We see that this lesion during insertion of the component and because of under-reaming required for the fixation of cementless acetabular component. To minimize the risk of fracture, we must choose component oversized by 2 millimeters. Patient fractures are osteopenia, metabolic bone disease, and osteolytic defects. And factors related to the technique are aggressive reaming and cup in which the ream circumference is larger than the nominal diameter of the cup. Diagnosis can be difficult. Full clinical and radio assessment area is required. And if there is a doubt in stability, intraoperative stress testing of the acetabular component, removal of the cup to fully examine the acetabulum. There are no really valid classification. The most used is described by Dal Valle. Type 1, intraoperative at the time of insertion of the component, and type 2, during removal of the component. The principles of the treatment are fracture stabilization, prevention of propagation of the fracture, maintenance of the component alignment, stability, achievement of fracture union. For non-displaced fracture with stable component, prosthesis can be left in situ, and standard protocol can be conducted. And the component unstable, structural integrity of the anterior and posterior columns must be assessed, and supplemental screws fixation should be used if necessary, like in the radio. Posterior column internal fixation not be sufficient in case of pelvic dissociation. We must do a fixation with a reconstruction cage and bone grafting. If marked instability and bone loss is still here, you use a larger acetabular component and a jump revision cup. In case of pelvic discontinuity, hemispherical cup alone is not sufficient, and we must use a reconstruction cage, like in this example, for hip dislocation, a congenital hip dislocation, and with the pelvic discontinuity and the use of Berschneider cup. For the prevention, preoperative planning to assess risk factors is mandatory. Full length and adequate preoperative radiographs is the solution. To appreciate any deformity or areas of bone loss that may increase susceptibility to fracture. Planification is important, like in this case, for osteoarthritis. But if we view the patient is a woman with a short woman with a body mass index about 51. In this in this example, we must use a special instrumentation, maybe a smallest size, but despite planification, there is a femoral fracture. Another example, a girl with femoral head necrosis, and as we see, we haven't made a small. We have small size X-ray, don't allow to see curved femur. Prevention is important with use of temples on preoperative radiographs, and the golden rule is if the implant chosen on the basis of the templating is not stable, inspect the femur to make sure that there is no fracture. Careful of the procedure associated with highest risk must be taken. During hip dislocation, cement removal in revision cases, canal preparation, and component insertion. Adequate soft tissue releases are necessary to minimize the force required to obtain sufficient exposure. If necessary, adjunction surgical strategies with trochanteric osteotomy. Cerclage wire at the distal of periprosthetic fractures is important to prevent propagation of the fracture. And we call next speaker. Fatwa?
Good afternoon. I'm going to break into the talks just to talk about really sort of fixation techniques in periprosthetic fractures. We've heard that hip replacement is the best operation that any orthopedic surgeon does, and I presume most of you are hip surgeons in the audience, so that probably gets nods and acceptance. These were some stamps that came out in my country at the turn of the century, just highlighting achievements in medicine. And you can see that actually the 60p stamp highlighted the hip replacement. But look closely, and it's a broken hip, a periprosthetic fractured hip with acetabular bone loss. So the hip surgeons in the UK were not very happy with this, and I'm very happy to say that within 2 weeks of this stamp coming out, we changed it. And this looks a much better hip replacement, doesn't it? And this is now the stamp that actually was with the package. But it just highlights that when hips go wrong, they can go very wrong. And we do need to have all the tools in our armamentarium to try and sort of treat these challenging periprosthetic fractures. Thank you very much for the people who've talked further, talking about the fact that we are having to put hip replacements in heavier people, more active people. But regarding to this talk, it's the elderly people that are the challenge. The fact that we've got an ever-increasing elderly population means, as we heard from Amoon, we're going to be doing these operations more and more. So it's good to see at 6:30 in the evening such a good turnout in the auditorium. These have poorer bone stock. They've had multiple surgeries. They are not fit patients. In my country, there's a standard of care that you must treat a neck of femur fracture within 36 hours. There's no such standard for periprosthetic hip fractures. So they often stay in bed for many days before organised theatre time. And that's a real shame, because during that time they often do deteriorate to a degree. So they're a poor, underserved population in our orthopedic community. And we've heard about the fact that, revisions are big risk factors. Uncemented hips, especially in the first, when you put them in, often do cause more fractures than cemented hips. But actually that difference between uncemented and cemented balances out after a few months. And then these are the classification. Now, Mamoon, sorry, I'm a simple man. So I'm just going to talk to you really about the fact that I think the Vancouver classification for femoral fractures is enough for me. So I think it does give you some form of understanding, but you've just got to understand there are some controversies, which I'll try and sort of talk about. And we've heard about the type A, B, and C. The management is really, there are a couple of different sort of options here. I'm not going to really talk too much about the type A and Cs. I think they're largely about wiring, and the C's largely about plating. It's the B, 1, 2, and 3. That's where there's some controversy. And you've hopefully, we're going to sort of, there is a little bit of intra-observer unreliability about determining that. So you've got to probably go into the operating theatre knowing that you might be dealing with a B2, but actually you might need an option for a B3 depending on what bone loss transpires as your operation continues. So ideally, just to emphasise, a prosthesis that's well fixed to B1, B2, the prosthesis is loose and good bone stock, and type B3, the loose but poor bone stock. And it's that subjectivity due to the fact about what implants you have and what your surgical skills are going to determine really about whether it's a B2 or B3. I do recommend a posterior approach for these patients. Identify the sciatic nerve, be ruthless about mobilizing and trying to get good exposure, but you've always got to maintain as much of those bone fragments and maintain that soft tissue, because ultimately you want vascularized fragments that you want to heal. These, I think, are the controversial areas. Do you fix the fracture or fix the arthroplasty in B1 or B2? And what's the quality of bone in B2s or B3s? They're the questions, and they're maybe the controversies that Mamoon brought out in his talk about the suitability of the Vancouver. But I think in some ways that you can answer this. So this is a cemented stem. Is this a B1 or a B2? Well, I'm going to say something controversial. I think if you've got a cemented stem that's got a fracture around it that's a B, that stem is loose. There's no such thing as a well-fixed cemented stem after a periprosthetic fracture. That's automatically going to be a B2 in my book. And so you're going to be thinking about doing a stem revision for this case. And in this case, I would have taken it out, and my workhorse is a modular, proximal modular taper fluted stem. I think that gives both proximal fixation, distal fixation, after you've reduced a fracture with various sort of wires, etc. And that gives a good sort of option in my hands. And this is at 6 months. It's nicely healed. The bone fragments have united, and there's been hypertrophy of the bones. That's a good fixation. So I think the modularity of these stems are really useful. The fact that actually you can get distal fixation and then close the fracture up around it. And you can then use the proximal modular aspect of the stem to really make sure you've got the offset, the leg length, and the version correct. So they're really helpful in difficult conditions to really optimize the post-operative mechanics for your patient. The proximal body has often got sort of this plasma splay or HA coating. So you get fixation both round the trochanter and also around the stem with the distal stem, and that helps you if you've got trochanteric fractures, etc. And then this is a distal fix, this taper fluted stem to get fixation in the isthmus. The nice thing is you've got different lengths, and you can go and sort of decide where you're going to get that isthmic fit. And then ultimately you also have bowed and cylindrical stems. If you've got long segment fractures, you can maybe sort of go even further down the femur, and you can do locking screws as well. So shorter, you can use this taper fluted, and then you've got cylindrical stems for the longer. So here you have a very long fracture that's got a cylindrical stem in, that's also got some supporting screws as well, and you can do some distal locking as well. And this is just sort of showing how you can get the trochanteric claw attachment if you need to, and try and get that fixation on that proximal body. The long spiral fractures are challenging. There's another implant out there called the Reef implant, which I think J&J still make. It's a completely straight, so it's not that bowed cylindrical stem that I tend to use. It's completely straight, but it's quite good if you've got a very long spiral fracture, and you can see that you can get the distal locking screws in as well to get fixation there. I've only done it a couple of times in my career. It's not an easy implant to use, but it's an option. So, uncemented B1, B2. Well, an uncemented stem has a good chance of being a stable and therefore a B1. A cemented, I don't think has. And so, in this case, yes, you've got the option of fracturing. When you're doing ORIF, when you're doing a plate, think about long working length, adequate proximal and distal fixation, at least 6 cortices. I don't like cerclage wires. I think they're inadequate. So now you've got sort of, with the AO Trauma Symposium coming up, they've got some really good plates now that are allowing you to sort of get screw fixation, whether it's locking screw or unlocking screw. Sometimes, however, you get this cemented stem, which has got a fracture, but you've got the real challenge, unfortunately, that you've got a knee stem underneath it. So what are you going to do there? So the knee is going to stop you actually potentially revising this to a taper fluted stem. Here, we took the stem out, we reconstructed the femoral tube, we put one of these really new quality plates. This is actually the ZB plate, and it's very similar to what AO now do for their periprosthetic fracture plates. There's locking screw options, there's unicortical locking screw options, and there's cerclage options as well. We reconstructed the femoral tube, and then this is the AO, and these are some of the things now that the AO are doing. Can you see now they've got sort of attachments that you can put actually on the plate, so you can put screws either side of the implant, called miss-a-nail technique. So they've got these nice little things, and obviously they've got extra cerclage wires you can use if you need to. They've got these long plates with these attachments to allow you to go down to the condyles or even up to the GT as well. So they've got a nice range of the plate system that you need sometimes in these challenging cases. So in this case, we had a plate on, we restored the cement mantle largely. There were a few little cracks in the cement, but the nice thing is you can do cement in cement revision. It's a really easy technique. You just put new cement into that tube, and you've got a new hip replacement. And the survival of the cement in cement is looking good now. It's sort of it's well under 10% failure, coming up to 10 years. So it's a relatively reliable, and I use it very regularly, cement in cement, if the cement mantle's intact, which it often is in the B2s. And then you've got, is this a B2 or B3? And it really will depend a little bit on sort of what your experience is and what your implants are. But yeah, you can see that's poor quality bone. But you can still, with some techniques such as strut grafts, you can restore that bone stock over a revision, and you can actually get some good bone healing with strut grafts. The trouble about strut grafts is availability. Not all countries have the availability to get strut grafts, and also the fact that you've got to be a little bit careful about your vascularity. And obviously, if you go down medially and you've also put something on laterally, you could destroy the vascularity. So be very careful about applying that and trying to keep it as vascular as possible to get it healing up. Finally, there is a role of quite radical surgery, limb salvage surgery. This was a 75-year-old lady, multiple attempts at trying to get this fracture to heal, which was really between at the bottom of the stem and of the knee. Ultimately, biology can be destroyed by your surgical attempts, and you need to be really careful about that vascularity. In this case, we had to take the whole femur out because there really was hardly any life left in that fracture, and no techniques, I think, would allow that fracture to be healed. So in this case, we ultimately did a total femoral replacement. It's a relatively straightforward operation for surgeons who've got some experience of proximal femurs or distal femurs, essentially just doing one and on top of the other. But look, you can get some sort of function despite this being a total femur in an elderly patient. At least we're getting her walking, we're keeping her out of a hospital bed, and not putting her through multiple operations. So my take-home message really is to use the words of Hippocrates, who's the father of our profession. He talked about extreme remedies are good for extreme diseases, and using sometimes a total femur is unfortunately necessary in some of these. I think the Vancouver classification in femoral fractures is useful, just to make sure that you realize that a cemented stem really can't ever be a B1. It's always going to be a B2. And then you've got to revise that as you have to do B3s. And sometimes in B3s, there is a role of an endoprosthesis. And ultimately, we're trying to get these patients quickly out of their hospital bed, walking and home, because we know that walking is man's best medicine. Thank you very much.
Thank you. So, you were very quick, and I understand all, and you have just speak about some parts of my part. So I will try to speak about only stem revision in 2022. As it is well known that periprosthetic fracture femoral shaft about hip arthroplasty stem are scarce. So the percentage after primary hip arthroplasty is varying between 1% to 2.3%. And the this fracture occur in 0.8% at 5 years after surgery and postoperatively, and 3.5% occur at 10 years postoperatively. After revision arthroplasty surgery, the incidence climbs to between 1.6% to 7.8%. The main topic of revision in fracture around the femoral stem is what is the status of implant. Is it there is loosening or no? If there is loosening, we speak about revision. Does it mean that we are going to exchange all the femoral stem? And if there is no loosening, we are going to do, or if does it mean open reduction and internal fixation using osteosynthesis device? The main goals of surgical treatment is to have a good alignment, provide stability of the hip, having early mobility, and lead to few complications in post-operatively. The principles of this treatment is to have a stable fixation, extensile incision, minimize at least soft tissue damage, and having revision of loose component to have an accurate fracture reduction in operation. What we have as options, we have two kinds of options. We have non-operatively treatment, which is based on limited weight-bearing brace, regular clinical and radiological monitoring, low threshold for surgery. On the other side, we have the operative treatment based on open reduction and internal fixation, which use plates, screw, cables, short allograft, and revision of the total hip arthroplasty with a specialist femoral stem and associated to ORIF. Based on the Vancouver classification as it was described and as it was published in literature, beginning to describe surgical procedure for each kind of Vancouver classification. Beginning go with the Vancouver type A. So there is no loosening of the prosthesis, and we speak about stable prosthesis. The option, surgical option that we have are non-operative treatment if there is undisplaced fracture, cable and grip and cable plate, or at the end the circulage wires. So the major indication for Vancouver type I, if there is lesser trochanteric periprosthetic fracture, are generally managed non-operatively with symptomatic treatment unless substantial medial cortex is involved. Second, protected weight-bearing assist devices, limited medial cracks are treated with 1 or 2 circulage cable. Greater trochanteric stable fracture are also managed similarly, does it mean non-operatively. In case of unstable and widely displaced greater trochanteric fracture, they are treated operatively with open reduction and internal fixation using only small plates or cable around the fracture. Claw plates are generally used, and distal fixation is with cables as it is mentioned in the X-ray findings. If substantial osteolysis is present, bone grafting is indication, and it's mandatory for the treatment of this kind. Now are seen together concerning the Vancouver type B1, where the prosthesis is well fixed. What are the options and surgical procedures that are available? We can use wires or cables, plates or screw or cables, cortical onlay allograft, or combination of all seated options. Well-fixed stable implant, you can use ORIF with plates and screw, cortical onlay allograft, or combination of both of osteosynthesis and allograft. If a ball plate are used to accommodate for the anatomy of femur, does it mean to the sagittal bow of the shaft? Long plates with extend to lateral femoral condyle are also used, and locus screws are used distally in case of osteoporotic bone, as it is mentioned in the X-ray findings. Concerning Vancouver type B fracture, distally we are obliged to use at minimum 6 to 8 holes of the plate, and 3 or more equal spaces cable are used on distally proximally between the lesser tuberosity and the tip of the stem. 2 screws are placed immediately distal to the prosthesis, and the distal extent of plate is secured with additional screw. So the difference between cheap ORIF fixation with cable or screw, it depends on the quality of bone, and especially in osteoporosis, it is recommended to use plate with screw and the plate of cable is used in case where we do trochanteric osteotomy. That's why we use it in this kind of Vancouver classification. These X-ray findings try to show whether are you going to use both screw, or you are going to use two circle cable around the stem when we speak about fractures type Vancouver type B. When type B2, when the prosthesis is unstable, revision is mandatory and associated with open reduction and internal fixation. We can use only in cementous prosthesis or cemented prosthesis. In type B, the revision of the stem is mandatory. And the additional of cortical strut allografts offer plunged construct of stability if we indicated a revision surgery for this kind of fracture around the stem. Concerning type B3, where there is a loss of bone, where there is no bone, we have to use osteosynthesis, but association with some specialized device in order to have a gauge of bone axial and rotational stability distal to the fracture side, and to save proximal fragment and allow proximal femur to restitute with a healing response. Together, B2, B3, revision of the femoral component is mandatory. What are the options, surgical options used? We speak about open reduction and internal fixation with lateral plate, or reconstruction of bone stock with allograft route, or combination between two osteosynthesis and allograft. A revision strategy should put into consideration some features, especially quality of ligament bone stock, diameter of the femoral canal distal to the fracture, and patient's factor like age and baseline functional status. Concerning the surgical hard step, there are some particularity of this surgery, especially the cement removal, which can be removed from the fractures, and we need to have some instruments and some devices in the operating room that can make it the intervention more easier. And we done, in some cases, especially B2 and B3, the femorectomy, or as it described in some papers as a trochanteric osteotomy extended, and it can allows for the surgeon an excellent access for the femoral stem and direct visualization of the distal canal to allow accurate reaming during the revision. Cementless long stem revision also can be used for treatment of fracture around the stem in osteopenic bone with Kappers scars. The kind of stem which is extensively covered in cemented long stem, prosthesis with or without lateral plate augmentation, can be used when the canal diameter is inferior to 18 millimeter, and simple fracture or 5 centimeter of parallel and distal diameter where is available. Whereas at the end, flute in titanium tapered modular stems are used if the cut diameter is more than 18 millimeters. In some cases, and as it is mentioned, in case of a big bone growth around the hip and around the femoral shaft, we have to use this kind of prosthesis as it was mentioned. Since it's possible in osteoporotic bone, we have to make a cement stem at the distal of the shaft, and the other side we use this prosthesis in order to have the stability of the joint. Another concept is the sleeve remnant proximal bone. It is used in this kind of prosthesis to make and try to make the soft tissue around the proximal side of the prosthesis. The tip of the stem is fixed with cement at the femoral shaft, and with a cable we can go to make the soft tissue around the prosthesis to ensure more stability. A brace is applied at the end of the intervention to avoid hyperflexion and adduction of the hip, which can give dislocation of the arthroplasty. Another technique is the internal scaffold technique, which can leave accessibility only through fracture lines osteotomy, and we can use the prosthesis as an internal scaffold pull sleeve of bone and soft tissue around it. Concerning the last type of Vancouver classification, which is type C, it's a fracture far from the prosthesis. So, what are the surgical options used to treat this kind of fracture? We have plates, we have screws, and cable. So what is recommended is usually these fractures are supracandular fracture or intercandular fracture. Lateral locking plate are the most used. Retrograde nail can be also used. Should be overlap distal femoral stem. Proximal fragment is fixed with multiple screw distal to the stem, and cable are supplemented around the plate to ensure more stability and to protect fractures far from the plate also. Reviewing the literature, we have to have as a summarize this table, which give us the major the major indication concerning periprosthetic fracture according to the Vancouver classification. And as it is as it is clear, for Vancouver tip I, we indicate functional treatment without surgery. So, on another side, if there is a displacement, we indicate surgery. But for type B, 1, B2, B3, and C, surgery is indicated and depend on the loosening. If there is loosening, we indicate the revision with the stem associated to ORIF option. Finally, I have to speak about this concept, which is the fracture of the stem. The fracture in the stem, sometimes it's described in 2014 in this journal, and it was described from 3 steps according to the proximal femoral fracture associated and communicated in the proximal part of the femur. So the indications are similar to the fracture around the prosthesis, which are, if there is only fracture of the stem, the indication is a revision only. And if there is a fracture of the stem and fracture around and loosening, the indication is fixation and reconstruction of the fracture. Thank you for your attention.
So. Thank you. Thank you, Mr. President. Thank you, Hamdi, for this good presentation. Donc, we will talk about outcomes following treatment of periprosthetic fracture of the femur and acetabular prosthetic fracture, and with a critical analysis of this review of the literature. Then, the bibliography was rich with many articles found and published for several years. We noticed different therapeutic attitudes with a variety of anatomical and functional results. In our study, we were interested in new articles, in particular those of the last decade. We included only the articles which treat the functional and anatomical results of the periprosthetic fracture of the hip, whatever the treatment realized. Approximately 100 articles were analyzed, the case series, meta-analysis, and systematic review. There were few publications studying the overall results after treatment of this fracture for all types of treatment. This is a recent systematic review published in the European Federation of Orthopedics and Traumatology, open reviews. We notice high morbidity with complication rates ranging from 13% to 22%, or even 30% in some series, and mortality rates around 10%. The functional results are worse compared to those encountered after surgical revision of aseptic prosthetic loosening. despite the presence of good radiological results with bone consolidation obtained in almost all cases. It is around 100% in most series. On the other hand, the longevity of the protheses after surgical revision cannot be estimated because of a low number of publications dealing with this subject. The treatment of femur fractures on hip protheses is still a subject of controversy, particularly for type B or C of Vancouver with a stable implant. There are authors who prefer reduction and osteosynthesis, open reduction of osteosynthesis, and others who opt for a prosthetic revision. This is a systematic review of 22 studies published in the Bone and Joint Journal. This review compared treatment outcomes for Vancouver type B2 and B3 of femoral fractures. It objectived a significantly higher rate of revision surgery for failure or complications after open reduction and osteosynthesis than after prosthetic revision. This is a meta-analysis that studies the factors of failure after treatment of a femur fracture with prosthesis. 245 cases of femoral fractures were revised for loosening, non-union, or fracture. The causes of revisions were also dominated by infection. The revision rate was significantly higher for elderly patients initially treated with osteosynthesis. The therapeutic results after prosthetic revision of femur fracture are satisfactory in the majority of cases. This is a meta-analysis published by the Journal of Bone and the Journal of Bone and Joint Surgery, which details the therapeutic results after prosthesis revision for type B2 or B3 fractures of Vancouver. Bone consolidation was achieved in almost all cases in all the series studied with a stable revision, prostheses that had not loosened at the last follow-up. This is a cohort of 70 patients treated by open reduction osteosynthesis or prosthesis revision. This study shows better functional results for prosthetic revision with a statistically significant difference. There was also a greater need of blood transfusion with a higher rate of postoperative complications for the group of patients who had an open reduction and internal fixation without significant difference. In this publication, the rate of complications after open reduction osteosynthesis was significantly higher compared to cases of prosthesis revision. In order to improve the therapeutic results and fight against complications, practitioners have tried reduction osteosynthesis with minimally invasive percutaneous surgery, and the operative time and blood loss were low with no postoperative complications. The functional results were satisfying with consolidation without reduction defects at the last follow-up. Other practitioners have proposed the addition of an allograft to an LCP plate to increase the chances of consolidation of their osteosynthesis. The duration of and rate of the consolidation were better in the allograft group, particularly for the type B1 of Vancouver, especially of the proximal location. There are several studies that focus on the contribution of cement in the treatment of fractures treated by prosthetic revision. Cemented revision stems provided significantly better functional results compared to uncemented stems with early and painless restoration of weight bearing, particularly more interesting for the elderly and without compromising bone consolidation. The publications collected studying prosthetic acetabular fractures are far less numerous than those studying femoral fractures. This is a study of 12 cases of periprosthetic acetabular fracture are all treated surgically by prosthetic revision, osteosynthesis, and acetabular reconstruction. The functional results at the last follow-up were excellent or good in 80% of cases. In this series of 24 cases, Pascarella does not report any surgical revision of all the cases treated surgically, which was also reported in other similar series. On the other hand, Peterson reports in a series of non-operative treatment a high rate of revision surgery amounting to 80% of cases. Prognostic factors have been collected throughout the analysis of several studies. These meta-analyses studies the impact of early surgery management on post-operative results regardless of the surgical technique considered. Surgery performed more than 48 hours after the fracture occurred was significantly associated with higher mortality and a greater tendency to develop postoperative complications. Similar results have also been reported in other studies with delayed surgery. Other prognostic fractures were significantly associated with higher mortality in the first postoperative year, such as comorbidities, poor bone qualities, and osteoporosis, and finally, the treatment by open reduction and internal fixation. And thank you.
If you have any questions in the room. So thank you for all speakers. Thank you, Dr. Duncan. Thank you, Dr. Kaziz, Dr. Barsawi, Dr. Zitouna, Dr. Benjmaa. Thank you for all the assistance. So it's the end of the day, and we will see you tomorrow.